Hi guys, I'm back again with another video in this whole series. Today I'm going to discuss about the deaf child. The deaf child is a topic which is practically important and also theoretically important. We will see it as a clinical case. Then we'll come to the etiology, diagnosis and what treatment can be provided to the deaf child. So now let's understand step by step. First, let's overview the clinical case. So, what is exactly meant by the deaf child? So, a children with profound means more than 90 decibel loss or total deafness fail to develop speech, and they often erroneously been termed as a deaf mute or deaf and dumb. But these children have no defect in their speech producing apparatus, but because there is a defect in the hearing apparatus, that is hearing loss, they never heard speech and therefore they do not develop speech. In lesser degrees of hearing loss, speech does not develop, that is not the case, but it does develop, but it's defective, and the period of birth to 5 years of life is critical for the development of speech and language. Therefore, there is need for early identification and assessment of hearing loss and early rehabilitation in this group. It was observed that children whose hearing loss was observed and managed before 6 months of age had higher scores of vocabulary, better expressive and comprehensive language skills than those diagnosed and managed after 6 months of age. So, emphasize the importance of early identification and treatment. So, guys, as we read, that was the case of hearing loss, that is a deaf child. A deaf child is also called as a deaf mute or a deaf and dumb child. So, now talking about etiology. So basically etiology we have divided in three forms. First is a prenatal, that is before birth, then there is a natal and there is a postnatal. So in these three forms we have divided it. First we will discuss about the prenatal causes. In prenatal causes we have again divided into infant causes and maternal causes. So, talking about infant causes, what is the first cause? Basically, we have to understand that an infant may be born with inner ear anomaly due to genetic or non genetic causes. Anomalies may affect the inner ear alone, known as non syndromic, or may form a part of a syndrome, that is a syndromic anomaly. So, basically, infant we have divided into a syndromic or a non syndromic anomaly. Next, anomalies affecting the inner ear involve only the membranous labyrinth or both the membranous and bony labyrinth. Those anomalies are, first in list we have is the skip dysplasia. What is skip dysplasia? It's basically the most common inner ear anomaly, and bony labyrinth is normal, and the superior part of the membranous labyrinth, that is utricular and semicircular duct, are also normal. So dysplasia is seen in the cochlea and saccule, hence is also called as a cochleosaccular dysplasia. It is inherited as an autosomal recessive non-syndromic trait. Second one we are going to discuss is Alexander dysplasia. What is meant by Alexander dysplasia? Basically, it affects only the basal turn of the membranous cochlea, and thus only high frequencies are affected. Residual hearing is present in low frequencies and can be exploited by amplification with hearing aids. Next is third one is the Bing Siebenmann dysplasia. So basically there is a complete absence of membranous labyrinth in this case. Fourth one is the Michael aplasia, which means that there is a complete absence of bony and membranous both labyrinth. If it was only membranous labyrinth, it would have been Bing-Sebman's dysplasia. If you are talking about both membranous as well as bony labyrinth complete absence, it's Michael aplasia. And we have to also understand that even though the petrous apex is absent, but still external and middle ear may be completely normal, non-affected, and thus here in this case there was a need of a hearing aid, in which case this Alexander dysplasia, but here no hearing aid or cochlear implantation can be used. The fifth one we have on the list is the Mondini dysplasia. Mondini dysplasia, what occurs in this is there is an incomplete partition between the scalae, that is scala vestibuli, scala tympani. There is an incomplete partition between them due to absence of osseous spiral lamina, and this condition may be unilateral or bilateral, and the deformity may be seen in Pendren, Vandenberg, bronchio otorhinol Collins, and Wilder-Wank syndrome. Okay, these syndromes are some different names. I'll explain them in detail afterwards. So basically the sixth one being the enlarged vestibular aqueduct. So what does this mean? Normal vestibular aqueduct is below 2 mm. Here we have used the term enlarged. So it's basically going to be more than 2 mm. And also we can see in type 2 of MRI, okay, early onset sensorineural hearing loss is seen, which is progressive. Presence of vertigo is evident, and perilymphatic fistula may also occur. Next, seventh one in cause we have is a semicircular canal malformations. So what is basically here? Both superior and lateral or only lateral semicircular canal malformation may be seen. So this was about basically maternal factor. Now, infant factor. Now we will discuss about the maternal factor. So maternal factor, what all we have? So in maternal factor we have basically infections which occur during pregnancy, drugs which are taken during pregnancy, radiation during pregnancy in first trimester exposure. So infection are basically torch infection which are common in this case. So the infections are STORCHES, known as torches infection. T stands for basically toxoplasmosis. R stands for rubella. C stands for cytomegalovirus. H stands for herpes simplex virus 1-2, and E stands for basically S stands for syphilis. So the mnemonic torches. Drug during pregnancy, multiple drugs such as streptomycin, gentamicin, tobramycin, amikacin, quinine or chloroquine, when given to pregnant mother, cross the placental barrier and damage the cochlea. Thus, thalidomide not only affects the ear but also cause abnormalities of limb, heart, face, lip and palate. Then as we discussed, there were radiation and other factors. Now let us talk about the perinatal causes. What are the perinatal causes? They basically relate to causes during birth or in early neonatal period. First we have is anoxia. Anoxia will basically damage the cochlear nuclei and cause hemorrhage into the ear. Placenta previa, prolonged labor, cord around the neck and prolapsed cord can all cause a fetal anoxia. Second one you see is the prematurity and low birth weight, that is less than 1500 gram. Then birth injuries, for example forceps delivery, they may cause intracranial hemorrhage with extravasation of blood into the inner ear. Fourth being the neonatal jaundice, that is bilirubin level greater than 20 mg% damages the cochlear nuclei. So basically here cochlear nuclei is targeted. Fifth being the neonatal meningitis, and sixth being the sepsis, and third was basically prematurity plus low birth weight. Seventh being time spent in neonatal ICU, and eighth being the ototoxic drugs. They are used for neonatal meningitis and septicemia. So postnatal causes are basically, we talk about genetic and non-genetic. Okay, so in postnatal causes, what we have as genetic and non-genetic causes, as you can see over here. So in basically genetic causes, there is basically we can say familial progressive sensorineural deafness or an association with certain syndrome like Alport syndrome or Klippel-Feil-Hurler syndrome. And in non-genetic causes, basically a viral infections like measles, mumps, varicella, influenza, meningitis, encephalitis, secretory otitis media, ototoxic drug, trauma, and noise induced deafness. Okay, now let's discuss a very important topic in this, which is basically evaluation of a deaf child, that is finding the cause. So basically the first step being the history taking in this, that is a detailed history is important of prenatal, perinatal and postnatal causes, family history, physical examination, certain investigation depending upon the cause suspected. So first step would be that the suspicion of hearing loss. Hearing loss is suspected if a child sleeps through loud noises unperturbed or fails to startle to loud noise, fails to develop a speech in 1 to 2 years. A partially hearing child may have a defective speech and perform poorly in school and be labeled as mentally retarded. And it is essential that all children at risk of hearing loss should be screened and followed. So basically, so the risk factor for hearing loss in children are first family history of hearing loss, then prenatal infections like torches, craniofacial anomalies including those of pinna and ear canal, then birth weight less than 1500 grams, hyperbilirubinemia requiring exchange transfusion, ototoxic medication including but not limited to aminoglycoside used in multiple courses or in combination with loop diuretics, bacterial meningitis and Apgar score of 0 to 4 at 1 minute or 0 to 6 at 5 minutes. So basically what and mechanical ventilation for 5 days or longer, stigmata or other finding associated with the syndrome known to be sensorineural and conductive hearing loss. Now talking about assessment of hearing in infant and children. So for assessment of hearing in infant and children, we have these methods such as neonatal screening procedure, ABR or OAE. Now I'll tell you about what is ABR and OAE in detail. So ABR means basically auditory brainstem responses and OAE means autoacoustic emissions. So basically what happens, I'll tell you. In OAE, that is autoacoustic emissions, these emissions are generated at the outer hair cells and can be picked up from the external ear as the energy produced by them travels in reverse direction, that is from the outer hair cells to ossicles to tympanic membrane to external auditory canal, and here is the place where it is picked up. If the autoacoustic emissions are absent, so if outer hair cells in the cochlea are non-functional or there is a middle ear effusion or canal debris due to meconium which may persist for about 3 to 4 days, then these are normal, which when the eighth nerve is non-functional, then it can be used in the diagnosis of neuropathy of the eighth nerve. Second, what we saw is ABR, that is auditory brainstem responses are generated in response to sound stimulus presented to the ear and picked up from the scalp. So basically with the response of almost 30 to 35 decibel NHL, the infant who passes the test and the hearing is considered normal, and infant who fails this test are followed to repeat the test. Next test what we have is a arousal test. Arousal test is basically a high frequency narrow band noise which is presented to 2 seconds to an infant when he is in light sleep. A normally hearing infant can be aroused twice when there is such stimuli are presented to him. Auditory response cradle. Basically the screening device for newborns where the baby is placed in a cradle and his behavior trunk and limb movement, head jerk, and respiration in response to auditory stimulation is monitored by transducers, and it can screen babies with moderate, severe, or profound hearing loss. Next is a behavior observation upon audiometry. Basically, what we see, auditory signal presented to infant produce a change in behavior, that is alerting, cessation of an activity, widening of eye, or a facial grimacing. Morose reflex is one of them and consists of sudden movement of limbs and extension of head in response to sound of 80 to 90 decibel. In cochleopalpebral reflex, the child responds by a blink to a loud sound. In cessation reflex, and infant stops activity or starts crying in response to a sound of almost 90 decibel. Next is distraction techniques for 6 to 18 months. Basically, what is there in this technique, that is these techniques are used in children for about 6 to 7 months old. The child at this age turns his head to locate the source of a sound. In this test, the child is seated in a mother's lap and an assistant distracts the child's attention, but the examiner produces a sound from the behind and one side to see if the child tries. So that was about distraction technique. Now about conditioning technique. First we discuss is visual reinforcement audiometry. Basically, it is a conditioning technique in which the child is trained to look for an audiometric stimulus by turning his head, and this behavior is reinforced by a flashing light on an animated toy, and thus the test have to determine the hearing threshold using standard audiometric technique. The auditory stimulus is delivered by headphone, or better still by inserting the earphone, which are accepted better and are also lightweight. And the test is well suited between the developmental age of 6 months and 2 years. Next is a play audiometry. The child is conditioned to perform an act such as placing a marble in a box or putting a ring. Basically, each correct performance is reinforced with praise, encouragement, or reward. Third is a speech audiometry. Okay, play audiometry was for about 2 to 4 or 5 years of age. Then we have speech audiometry. The speech audiometry child is asked to repeat the name of certain objects or to point at them pictures, and the voice can be gradually lowered. In this way, hearing level and speech discrimination can be tested. The test can also be used to example of child's expressive ability when is asked to name the toys like horse, duck, objects like cup, plate. Next are the objective test. In the objective test, we have first we have is basically evoked response audiometry. In this, we have two things. We have basically electrocochleography, and second one is the ABR. So what is electrocochleography? It can measure the auditory sensitivity up to 20 decibels. Okay, and also it is an invasive procedure requiring placement of electrode through the tympanic membrane. Then what we have is a ABR. ABR is not a direct test of hearing, but it correlates highly with the pure tone threshold. Identifiable waveforms is basically up to 10 to 20 decibels. Next, what we have is a OAE, as we discussed, autoacoustic emissions, transient evoked emission, and we have also impedance audiometry. So what is this impedance audiometry? Basically, normally stapedius muscle contract reflexly in response to a sound of 70 to 100 decibel, and they contracts and this reflex can be recorded. Absence of acoustic reflex indicates middle ear disorder. Retrocochlear behavior audiometry. Acoustic reflex are useful component to cross check, and the absence of acoustic reflex but a normal tympanometry with parental concern for hearing loss suggests a possibility of SNHL, that is sensory neural hearing loss of severe to profound degree, and the absence of acoustic reflex but abnormal tympanogram generally indicates conductive loss, but ABR and OAEs provide more information. Use of acoustic reflex in the assessment of pediatric testing has declined. Now what we will talk about is the management, basically how to manage it. It is essential to know the degree and type of hearing loss and other associated handicaps such as blindness or mental retardation, whether hearing loss is prelingual or before development of speech or postlingual. Etiology of hearing loss remain obscure in about half of the cases. So what is important is basically we have to understand through this diagram in detail. As you can see in this diagram, if basically hearing is impaired, most important is basically the parental guidance of great emotional shock. Hearing aids, we can see visual and also cochlear implant. What now is visual faculty, auditory faculty, and tactile faculty, in which you have written language, lip reading, sign language, sound signal, hearing aid, cochlear implant, and vibrotactile aid. Also, we have oral speech and expressive skill, line, sign language, of finger spelling, and written communication like letter and electronic media. So yes, guys, in this video we actually discussed in detail about. Sorry for the disturbance, guys, but yes, in this video basically about a deaf child, we discuss about the etiology of deafness and also how to evaluate, how to assess all the things in detail, and lastly we saw management as a quick summary. There is another big chapter on as rehabilitation of deafness, like how in practical and clinical view actually deafness is treated. It's a very important topic. This was also an important topic. I hope it got well summarized and well explained. I hope so. Thankful for your patient hearing. Stay tuned.